keep going. All right, work me through this one here.
Okay. Um, what is the most appropriate management for this patient's condition? 30-year-old woman presents with a 6-month history of hirsutism, amenorrhea, and acne. Physical exam shows male pattern hair growth, acne on the face, chest, and back. Lab findings show elevated serum testosterone and normal DHEAS. Pelvic ultrasound demonstrates a 3 centimeter mass in her left ovary. Most appropriate management. So, I think first diagnosis to me sounds consistent with PCOS. She's having like the elevated um, testosterone. Well, yeah, I'm gonna say PCOS. So then we need to
Okay.
figure out how to treat it. So we want to uh okay. Well, wait. I'm sorry. 30-year-old woman, a mass in her left ovary. Are we actually concerned this might be like a germ cell mass and that's why we have the elevated testosterone?
Okay, that's on your differential. Okay, good. I like how you're thinking.
Um, 3 centimeter, 3 cm. Okay. Um, okay. Can we X off like the observation and the radiation? I at least know. I think we want to do more than that. Um,
Okay.
spironolactone would help with like well, okay. Um, okay, I'm gonna go with my original differential or original PCOS. So I don't
Okay.
think we need to do laparoscopic removal of the mass. So
Okay.
then it's just figuring out if we put her on I would put her on like an OCP and see if we can't get her like ovulating normally and hopefully help with some of this.
So actually, right. So remember, PCOS, what does PCOS stand for? Let's start with that first.
Polycystic ovarian syndrome.
Okay. Do you have one cyst, multiple cysts, bilateral, unilateral? How's it look?
It would be multiple bilaterally.
Yeah. Yeah. So with an ultrasound, you should see multiple cysts if it's PCOS. Does it make sense?
Yes, sir.
So the fact that there's only one, you got to be highly concerned that kind of with your other differential, you're like, oh, maybe this is a germ cell Sertoli tumor, right? So that's really kind of what I'm thinking about here, right? Is that you have a unilateral mass on kind of the left ovary that's unilateral. 3 centimeters is pretty big, and she's having kind of elevated testosterone. So you're thinking about like a Sertoli or Sertoli syndrome, secreting tumor, right? Or androgen secreting ovarian tumor, which you want to actually take out, right? That's going to be the only one. And but I like your differential and I like how you're thinking. The key here is the imaging, right? The imaging here is going to be the key to differentiate between PCOS versus, right, a singular ovarian mass secreting androgens. So I think that you picking PCOS, that's okay. You like committed to a diagnosis and then you pick the correct treatment option for that diagnosis. You know what I'm trying to say?
Yeah.
So I think the key here is, I feel like if you're like, you know what, I think this is, a Sertoli tumor or, an androgen secreting ovarian tumor, then you would have picked, let me get that thing out. So
Do you know what the hormone imbalance is in PCOS? Is it elevated testosterone?
yeah, it's also you also get elevated testosterone. That's because you have a higher LH to FSH ratio. So you're kind of in a sense always in a sense, right? You're always in kind of this hyper ovulating state, which is why you have so many like follicles, right?
Uh-huh.
Or aka you create like a lot of cysts. And what ends up happening is because the imbalance, once again, I'm not an expert of PCOS by any means. Okay. So, take this with as much with a grain of salt as much as I can, right? I'm giving you the high yield stuff. Of course, there's probably small details that I'm not telling you about, but
Yeah.
because of the hormonal imbalance, that's why you have a lot of things go on. So in one sense, right, you have amenorrhea, right, because I think you have way more estrogen, right? So it's like a natural birth control there, right, because you have an imbalance of estrogen and progesterone. Number two is that because I believe you might have to check on it again. Once again, I'm pretty sure that because you have so much estrogen, it then converts the extra estrogen into testosterone, which is why you have elevated testosterone too. So you have hirsutism from that for PCOS, but also remember they like to test you that you have an increased risk of diabetes, right, with PCOS also.
Insulin and sensitivity.
Yep.
So on, I'm sorry, you can tell me if like we're getting too in the weeds, but on PCOS, because the estrogen is being converted to testosterone, we would just have like normal DHEAS, right?
Um, that I'm not 100% sure on.
Okay.
Because the DHEA, I can't remember the exact pathway. Let's look at some of our tools here. Testosterone, what makes DHEA? Let's see. It's primarily produced in the adrenal gland with small amounts synthesized in the gonads and brain. So, what diseases are DHEA elevated? Adrenal tumors, PCOS. So it is increased in
Okay.
PCOS and then congenital adrenal hyperplasia. So yeah, so it depends. I think I always, the way I remember it, it's not really asked too often about DHEA, but it's like a this sounds interesting, but it's like testosterone and steroids, right? It's just more physiologically potent. It's just like a more, it's a more potent testosterone is how I remember it. So
Okay.
they don't ask you too much about it, I would say for the most part. Um, so don't kind of narrow your answer just based off that particular hormone, if that makes sense, right? So you want to take this as a overall holistic thing, right? So I think you did really, really good up until the practically up until the imaging. You had kind of the scenario down. You're like, oh, this fits PCOS, but then the ultrasound is going to give it away that it's a singular mass causing the increase in testosterone rather than a PCOS kind of picture.
Yes, sir.
Perfect.